So, first of all, welcome to this first webinar. This is run by Joyce, you, and myself, and I'm going to give you some more names in just a second before Joyce kicks it all off. But I just wanted to say thank you for so enthusiastically joining this webinar. This was the idea of a fellow in training, Brian Kelly, and I want to give him full credit because this was actually his idea. He thought it would be great to have something like the summer school, but to have it sort of throughout the year. So this is our first one, and I'm sure there will be things that work great and things that don't work so great. We will be asking you for feedback at the end. I want to point out that this is sponsored by CIS and USIDNet, and I think LaCide will also probably become a sponsor in the future. We're very excited to have this the entire hemisphere, all of the Americas, and you'll see that the cases are, I think, really outstanding and that they show the complementary training and experiences that we have from different parts of the world. Because this is sponsored by CIS, I want to remind you, if you are a trainee, you get membership to CIS, which you certainly want. It's an amazing benefit. You get discounts for reading, you get access to the journal. It's really, it's quite a wonderful perk, I think, and it is free for trainees. So remember all of that. And then for this particular phone call, I've invited some faculty. Joyce, you and I are the two that are helping organize this, but of course it never happens alone. And so I want to acknowledge the faculty tonight who are Leanne Kearns, Elena Perez. I did not see Sergio Rosenzweig log on, but he should be joining us. Morna Dorsey and Jen Heimel. I also want to thank Missy Dortman and Jesse Cunningham from CIS setting up this platform. This is new for us, and we needed a lot of help to learn this software, and you'll probably see some learning that goes on throughout the next hour. There will be some learning, I'm sure. So the presenters tonight are Joyce Yu, who's going to do a literature review. We hope to do this every webinar, sort of highlight the latest and greatest things that we think everyone should know about. We then have three presenters for a case from Brazil, Otávio Marques, Juliana Leite Mazzucchelli, and Mariana Gouveia Pereira. They're from the Federal University of Sao Paulo. Bom dia to you. And we have Kiran Patel presenting a case of lymphocytosis from UCSF. And I think with that, I think Joyce will kick it off and tell us what's been going on that's really cool.
Excellent. Thank you, Kate. Wait for our slide to come up.
Have a choice. It's up for me.
Okay. I think it's opening. Right, Kate? Oh, here we go. Okay, there we go. Thank you for having me. So we just want to do a quick literature review on some articles that we wanted to highlight from the JOCI. So the first article that we wanted to kind of highlight was Fertility, Pregnancies, and Outcomes Reported by Females with CVID and Hypogammaglobulinemia. This is an internet-based survey that was completed by 490 CVID and 100 hypogammaglobulinemia patients who were registered with the IDF. Some of the findings that they note is that amongst this cohort, they found that there was a decreased birth rate or rate of births versus the general birth rate. However, they didn't think it was due to an increased rate of pregnancy loss. Interesting, many of these patients actually did not have a PID diagnosis before their pregnancy, but fortunately, many of them didn't have a serious infection during their pregnancy. Of the ones who had been diagnosed with a PID or CVID or hypogammaglobulinemia, many of them were continued on their immunoglobulin therapy during pregnancy, and about a quarter had increased dosing. And overall, no one had any serious side effects from the IgG therapy during their pregnancy. And one of the take-home points of this paper is that this is a very interesting self-reported population survey from their peers with PID, and so it can help you with your counseling of other PID patients who are pregnant or are trying to get pregnant. So moving on to our next paper that we wanted to highlight was Infectious and Immunologic Phenotypes of MECP2 Duplication Syndrome, which is a syndrome associated with X-linked intellectual disability, or Loeb syndrome. This is characterized by hypotonia, dysmorphia, developmental delay, and autism. And a majority of these patients, or a large percentage of them, have been noted to have recurring respiratory infections, and in some of them it has actually been fatal. The authors for this paper noted that the infection profile primarily consisted mainly of pneumonias. That was the most common infection, but some of these patients also did have pretty serious sepsis as well as urinary tract infections. The most common bacteria that was found to be the trigger for these infections were the encapsulated bacteria, especially the strep pneumonia and the H. influenza. And in these patients, they found an immunologic profile consisting of decreased IgG2 levels as well as some IgA levels, and many of these patients also have decreased specific antibodies for pneumococcus. Interestingly, many of these patients had, on the other hand, very increased IgG1 and IgG3 levels, and a large number of these patients, well, of the 10 patients that were tested, majority of them actually had very robust acute phase responses with very high CRP levels, and the authors proposed that this could be maybe associated with duplication of a neighboring IRAK1 gene. No gross T-cell abnormalities are found in these patients, and this paper illustrates, the importance of us recognizing or defining immune deficiencies and other genetic syndromes that are out there, and realizing that other genetic syndromes do have specific immune deficiency profiles associated with these other syndromes. The next paper.
Can I you at that moment? We have lots of people on the webinar, but I wonder if folks could use the chat over on the left to just say if you've seen this syndrome. I saw my first one just a year ago, and honestly, she's just like this description. And at that time, there was nothing in the literature about immune deficiency. So have other people seen this duplication syndrome? If you could just sort of quick type in the chat section.
Great. So the next interesting paper that we wanted to highlight from the JOCI is titled Identification of Patients with Rag Mutations Previously Diagnosed with CVID Disorders. So in this paper, it's a series of 2 patients who presented very early on with autoimmune complications, recurring cytopulmonary infections, as well as hypogammaglobulinemia, and they were diagnosed as possibly having CVID and started on IVIG. Ultimately, both patients were discovered to have compound mutations in RAG1. One patient was diagnosed with home exome sequencing, and the second patient was diagnosed with a gene panel. And as you can see here, there are 2 different compound mutations. Interestingly, the second patient was also also happened to find a mutation in the BAFF receptor gene. However, it was considered not significant or not contributory to their immune deficiency. And the take-home message with this paper is, again, that this is an example of an atypical presentation of the common PIDs, no pun intended. And it's just a take-home message is to really consider other diagnoses when you see patients with atypical presentations of what would seem to be a common immune deficiency, particularly given the variable spectrum of SCID patients. And another take-home message is to think about that advances in next-gen sequencing perhaps can be used to help determine the cause of genetic defects in some of these mystery patients who we can't quite put our fingers on. So the next paper, and the very last paper we wanted to highlight, was combined immunodeficiency involving into predominant CD4 lymphopenia caused by somatic chimerism in JAK3. In this paper, the authors described 2 female siblings from a consanguineous family with combined immunodeficiency. It was basically these two siblings had initially some CD4 lymphopenia, some mild IgG2, IgG4 deficiency, and eventually they were noted to primarily evolve into having a CD4 lymphopenia with very mild antibody deficiencies, nothing terrible to write home about. However, both of these patients were noted to have with homozygosity mapping and exome sequencing. Both of these patients were noted to have a homozygous mutation in a conserved area of JAK3, and that was confirmed by decreased signaling through JAK3 dependent pathways. Subsequently, they did Sanger sequencing and sorted CD4, CD8, and B cells, And they found that in both patients, they had somatic chimerism in their CD8 positive T cells. And in the patient that was the one that was less immune impaired, she actually had some revertant CD4 positive T cells, which suggested maybe that would contribute to why her immune picture was a little less severe. And the take-home message in this paper is that, this is another case of variable defects that are seen in a known SCID gene, which can be associated with mild common immunodeficiency phenotypes. So important things to think about is, now that we're starting to realize we should, when we see variable phenotypes associated with genetic mutations, we should consider hypomorphic mutations as a possibility. And these authors also suggest perhaps the role of somatic chimerism contributing to these two patients, kind of combined immunodeficiency phenotype, but not quite SCID phenotype. So those are some papers that we wanted to highlight from the JOCI. I encourage you to log into your account and fill up these papers and do your own reading.
So I just put up a little poll for people just to actually see if I could do it. And while you are answering the poll, I'm going to ask Missy, do we have all of the Brazilians on, or should we start with Kiran Patel's case?
I think I'm here. I'm Juliana.
Juliana, welcome.
Hi, how are you? Hi, everyone. I think we can start.
Okay, let's give folks, can everyone see the poll that I put up just for my education?
Yes.
Yes.
Okay, so I'll give people 1 minute to vote, and while that's happening, I'm going to pull up the hyper-IgM case. Our idea for how this will work is we will have Mariana, Otavio, and Juliana present this case. It's a really interesting case. There's lots of aspects that are interesting, but I'm going to have them go through it and not present it as a mystery case because they pose some very interesting questions at the end. And so we'll have them go through it. It'll take about 5 minutes, and then we'll try our best to figure out how we can have a discussion with this many people. And so Mariana, Otavio, and Juliana, please take it away however you want.
Okay, I think Mariana can start.
Okay, I'm going to start. Hi, my name is Mariana. I'm going to present this case with Otavio, and Juliana is going to discuss, as we were saying. Well, our patient is a male. He was born in September 1993. He's the first child of non-consanguineous parents, and he was born at term after normal pregnancy. His birth weight was around 3.8 kilograms. There was no family history of immune deficiency, and he was a thriving baby with good growth recorded. He received all the vaccines available at that time, including BCG according to age, without adverse effects. By the time he was 6 months of age, he was hospitalized for 15 days due to a respiratory distress. A diagnosis of pneumonia caused by Pneumocystis jirovecii was done based on bronchoalveolar damage. He had been on confirmation of the treatment at that time, but he recovered well and was discharged home. At 4 years old, he started several episodes of stomatitis and respiratory tract. At 5 years old, he had periorbital cellulitis that was treated with oral antibiotic and at home with low complications. At the age 8, he was admitted to a hospital for 7 days due to a bacterial pneumonia. Only at that time, immune deficiency was suspected, and he was referred to our clinic. Those are his first laboratory findings. You can see a low IgG and IgA serum levels. He had raised IgM levels, is about 400, and you can notice as well a mild neutropenia. Okay, because of these results, X-linked hyper IgM syndrome was suspected, and now Otavio can tell you about the molecular diagnosis.
So hi everybody, it's a pleasure to be here and to participate in this interesting meeting. So the patient showed no expression of CD40 ligand despite normal expression of CD69. Then we have sequenced the CD40 ligand cDNA, and then we found the deletion of the exon 3 of this gene and a gross insertion in the splice siting aside the exon 3. That is the captive mutation for the leading to this phenotype of this patient.
Otavio, can I ask a question?
Yes.
Otavio, has this mutation been seen before?
Yes, it's a previously described mutation, exon 3 deletion. Exon 3 skipping has been found in 2 or 3 patients which are registering the CD40 ligand base. It's a previously described mutation.
And I notice in the picture that you have of the protein that the protein is very, very truncated.
Exactly. The protein is actually unstable and is not expressed and cannot be recognized by the monoclonal that we have used.
And within patients with X-linked hyper IgM, is there a genotype-phenotype correlation?
Actually, so far, it's very difficult to make a genotype correlation because the mutations, they are very heterogeneous, and the clinical presentation, they are also very different, despite some very common features as pneumocystic carini and cryptosporidium. However, the presentation can vary depending of the patient, despite the patient share the same mutations.
And Otavio, there's a question from one of the attendees as to whether this mutation is exclusively on T cells.
I didn't hear well, sorry.
There is a question on the chat asking if this mutation was seen only in T cells.
No. This mutation is in the genomic DNA. It's spread in all the cells of the patient. Not
Yes,
exclusively in T cells.
as far as I know, somatic mutations have not been associated with this phenotype. Let's go on.
Yes. I'm going.
Yes. Okay, can continue.
You want to say something, Ju? No?
No, you can go ahead.
Okay. Well, after the diagnosis, we started cotrimazole prophylaxis and IVIG therapy with a dose of 600 to 700 milligrams per kilogram every 4 weeks. Hello? Are you listening? During the regular IVIG therapy, at 11 years old, he presented with persistent fever, cough, and dyspnea. After 13 days of treatment with oral antibiotics without improvement, he was hospitalized for an investigation. A chest tomography showed mediastinal lymphadenopathy, and a lymph node biopsy was done and revealed blastomycosis. Hi. Everybody's listening? Because I can listen.
Yes.
Okay. lymph node biopsy was done and revealed blastomycosis due to Paracoccidioides brasiliensis, the South American blastomycosis. And he was treated with itraconazole about 1 year with CT scans control normals. At 19 years old, he presented fever, weight loss about 14 kilograms, and lymphadenomegaly again. He was hospitalized. At the time, we were afraid of blastomycosis again, and a cervical lymph node was biopsied and tested for fungus and mycobacteria. He had a necrotic lesion of the nasal wing and also was biopsied, and he were diagnosed with tuberculosis in both material. He treated with anti-TB drugs for 6 months, and then he abandoned the treatment. Well, currently, the treatment with good compliance, but he has poor compliance to cotrimazole prophylaxis, GCSF, and mycobacterial treatment. He had drug abuse and still have symptoms like persistent cough. His last IgG level is around 700 milligrams per deciliter and maintain a mild neutropenia around 1,000 neutrophils. And now to finish, we have some points to discuss. Juliana?
Yes. Can you hear me well? So as we can see, this patient more recently has represented a problem in terms of compliance for us. He's never finished his treatment for tuberculosis properly, and he refuses to take Bactrin daily or to use the GCSF sub-Q injections. But I think what's very interesting about this case that I'd like to comment on is about the infection with paracoccidioides or PB mycosis, the South American blastomycosis. We know that in hyper-IgM, fungal infections are more frequent in the first 5 years of life, and then they tend to be much less common thereafter. But this patient had PB mycosis later. He was already 11 years old, so I think this is interesting. The fact that he had PB mycosis is actually consistent with the epidemiology of the disease in Brazil. PB mycosis is the most common endemic mycosis in South America, and it's actually its incidence is higher in Brazil. And it's higher in São Paulo state. That's where we are, and that's where the patient is from. But what's curious is that he lives in São Paulo City, which is a huge urban area, and the PB mycosis is much more common in the rural areas, not in the urban areas. But and it's also interesting to say that he had a so-called acute juvenile form of the PB mycosis, which is not the typical patient, which is usually an older male that works in agriculture and so on. So this is interesting. And also, the lungs were not the primary site of infection. That's what it's seen in this type of juvenile form of PB mycosis. And then I also like to mention that Otávio and Dr. Condino's group published a paper in the Journal of Clinical Immunology in 2012, which showed an unusual high incidence of fungal infections in a cohort of 11 patients with X-linked hyper-IgM. So 9 out of 11 patients had fungal infections of some sort. And this case was among one of those cases. This was the first case of PB mycosis described in CD40 ligand deficient patient. So Otávio, would you like to comment on that?
You have made a very good presentation. I just would like to say that this patient, we have found also dendritic cells dysfunctions that we have published in the same year in JACI. And additionally, we are now characterizing some dysfunctions in macrophages and also in neutrophils that we are we hopefully soon conclude this study in this year or in the maximum in the next year to send this to publication. Just what I have to say.
We have a couple of questions on the
I
chat
see, yeah.
room. Could you, I guess everyone can see the questions. Can you tackle a few of those for us?
Yes, yes. We assumed that how do you say? We haven't identified the mycobacterium, but we presumed that he had mycobacterial tuberculosis, not bovis infection. Okay, and because he has, does he use illicit drugs? Yes, he has a history of using marijuana, maybe cocaine, and then yes. What does it say? Does he? We have seen that.
Blastomycosis from marijuana.
Yeah.
Yeah, it might be a source of the for the infection. Yes.
So we'll need to finish up, but I want to get to the questions that the case posed. But you've taught us some very important things. So for hyper-IgM specifically, you've talked about susceptibility to PB mycosis. Are there other fungal infections, fungal infections in South America associated with X-linked hyper-IgM?
Otavio, I think you correct me if I'm not wrong. If I'm right, I'm not right. I think you showed that there's 10 times more infections with Candida, right? Or not for hyper-IgM. I think for in general, right? There's more Candida infection and.
As Candida infection has been described previously in CD40 ligand deficiency, we have described a higher incidence. However, we also find another patient, I think his name is Pedro from Brazil. He had aspergillosis, and another patient also from Argentina was described with aspergillus. As far as I remember, is just these cases.
Thank you. Let's open it up to some of the faculty that have joined us. So we've got Leanne Kearns, Elena Perez, Sergio Rosenzweig, and I think Morna Dorsey and Jen Heimel. It's uncommon to see fungal infections in the United States in X-linked hyper-IgM, but I wonder if we open it up to the larger group, have other people seen outside of PB mycosis that we just heard about, which is endemic to South America, have other people seen deep systemic fungal infections? Would the faculty like to comment?
I have not.
Elena, Leanne, Sergio?
No, nor have I. I have not seen any.
Sorry, Kate, I would like just to make a brief comment that a big difference between the United States and the Brazilian population in South America is just the access to the treatment. I think the patients in the United States and Europe, they have much more access to bone marrow transplantation, and then this makes a big difference because they are treated very quickly.
I think that there's definitely truth to that, but I'm old enough. This is Kate speaking. I won't pretend to be someone else, but I'm old enough that certainly I remember through most of my time as an immunologist, patients with X-linked hyper-IgM were not being transplanted. And so the reason I'm asking is it strikes me that it's a pretty big difference between PB mycosis, and there must be something different about that fungus, because we don't see histoplasmosis, we don't see aspergillus. I'm sure it happens, but it certainly isn't nearly as common as what you're describing. So I'm just wondering what's unique about that fungus that seems to be able to exploit this flawed immune system.
Oh. Okay. Hello. Okay. I'd like to comment something about the bone marrow transplant, because I guess There's a question about if the patient has an identical donor. No, he's a single child, so he would need a matched unrelated donor. And for him, I think there are also the issues of compliance and presumed drug abuse. And he's old, he's already 21 years old. There were only 4 cases of BMT performed for hyper North America. 2 were in Brazil, 2 in Argentina. They're all alive and well, but I don't think this will be an option for him. We have a very available, very few centers that have this procedure available in a case like this, so it will be difficult, I think. No, he doesn't have liver problems. I see someone is asking. And I think he never had cryptosporidine. He had giardia, but he never had cryptosporidine. Another interesting thing I like to comment, just I know we have to finish, is that about the neutropenia. This patient always had mild intermittent neutropenia, and at the time that he had the PB mycosis, he had no neutropenia, neither 6 months prior or at the time of the diagnosis. So I think this is interesting too. He was not on G-CSF. He actually was started on G-CSF later on when he had tuberculosis, and then he was really neutropenic.
This is a really interesting case, and in some ways he's done far better than I think a lot of us would have expected in the many comorbidities that he has. But you're in a difficult place, to be sure. He's not very compliant. He hasn't probably cured his tuberculosis. I can tell you at our center, he would be a candidate for transplant, which is not the same thing as saying that we would do it. We would have pretty significant reservations because of his compliance issues and because of his past drug use. But he certainly we would have a meeting about him and we would have a discussion. I don't know if that's comparable at other centers. Some of it would depend, if he had drug abuse 5 years ago but is now a model citizen, we would think differently than if he was still using cocaine every time he was discharged from the hospital. So there are lots of things to take into consideration, but he would at least be a candidate. Other centers that would feel quite differently? Like, we don't have total consensus, but we have consensus. So are there any last questions for this interesting case? I think it really does highlight some of the clinical patients that are different in different locations around the world. I was really thrilled when they submitted this case. I think it's really beautiful. Are there some other questions popping up? It looks like the general consensus is that folks would think about it, but very cautiously. Are there any last questions for any of the 3 presenters, Ottavio, Juliana, or Mariana? All right, then I thank you very much for this presentation. It was really perfect for this first webinar, and I thank you so much for the time and energy that you put into it. I'm now going to bring up the second presentation, which will be presented by Kieran Patel.
Thank you.
Okay, so my presentation is going to be on a patient who presented with lymphocytosis, which tends to be a rare thing for our clinic, at least. And everybody can hear me?
Yes.
Yep, you're doing well.
So this is a 16-month-old male who had a history of leukocytosis, and this was actually initially found on ABCs that were sent because he had a history of recurrent, highly febrile systemic reactions to vaccine. Typically, he would have fever as high as 104, and then this associated macular-papular rash after vaccination, lasting anywhere between 4 to 5 days, and no sort of clear etiology was found. He also had a history of developing chickenpox after the live varicella vaccination, which took about 2 months to resolve on its own. He was never hospitalized for any of that. He also had a prior history of 2 ear infections that required standard oral antibiotics, and no history of any systemic infection or sinopulmonary infection. He also had this sort of odd history of refusal to bear weight intermittently. The episodes would last anywhere from 24 to 48 hours, and the parents and doctors never noted any sort of swelling of any of his extremities or erythema or rashes with these intermittent bouts of refusal to bear weight.
Karen, do you want to stop there and just not much history to go on, but just try and take the temperature of what people are thinking?
Sure.
I've been trying to use the polls, but I can't quite make it work. Do you want to use the chat room and just sort of give a flavor for what you're thinking of at this point? We've got some vaccine reactions. We've got a little bit of limping here and there, 2 ear infections. That looks like we have only one brave person positing an answer. I think there's more of you out there than that. Be a little brave here. We're all friends. Do you want to tell us yet how high the light count is?
It was pretty high. It ranged anywhere between 50,000 to 60 to 70,000.
So we definitely are seeing some anxiousness about this story.
And yes, it was a similar reaction to MMR. So when we saw him in clinic, in terms of a review of systems, we had a history of a delay in tooth eruption, as well as he had sparse hair on physical examination. He had a history of diaper rashes that required topical antibiotics and antifungals. He had eczema on his cheeks and arms, and he actually had hepatomegaly on exam as well. Family history-wise, there wasn't any history of recurrent infections or known immunodeficiency in the family, and no history of consanguinity either. He did have an 8-year-old brother who had a history of ADHD and speech delay and color blindness, and this interesting history that he had 4 bouts of supposedly RSV infection. The first RSV infection required hospitalization, the subsequent 3 did not. And he also had an 11-year-old sister who was completely healthy.
So now you've got more information, folks. Not a lot. Kieran's being a little stingy here, but you have a little bit more information. Does anyone want to posit some more ideas about diagnosis here? Got a lot of focus on the umbilical cord.
And it sounds like there was no delay in the umbilical cord falling off initially.
And of course, everyone remembers that in LAD, only about 10 to 15% of the patients have delayed separation of the umbilical cord. History. All right, there's some good hypotheses out there. Kieran, you want to go ahead?
Okay. So the initial laboratory evaluation, we had a normal CMP, but this very striking elevated white count of 59. The predominant white cells were lymphocytes at 36,000, and then ANCs followed by monocytes. We had elevated inflammatory markers on several occasions. And then when we did an immunophenotype panel, the majority of the cells were T cells, with about 14,000 being CD4 positive and another about 5,000 being CD8 positive, and very little memory cells in either CD4 or CD8 compartment. The CD9 compartment showed a decrease in total memory B cells and an increase in the transitional B cells. And then he also had elevated NK cells. We did some further...
Can I just make a tiny pearl point here? So if you look at this CBC, the neutrophils and lymphocytes and monocytes are all increased. Is that a pattern that one would see in LAD? The answer is yes. So many people think it's just the neutrophils that are increased in LAD, but that's not the case. You see all three lineages markedly increased in LAD for reasons that I've never been able to ferret out. So I will say that Kieran has now given you most of what you need to really make a pretty confident diagnosis here. Do you want to, some people are kind of crystallizing on a couple of ideas here. Do you want to put forth a couple more ideas about diagnosis, and then we'll let Kieran go on? Right, I think you can go on.
We checked the rest of his immunoglobulins, and he had an undetectable IgA, a low IgG, an elevated IgM. He had no vaccine response to any of his live vaccinations or his killed vaccinations in terms of pneumococcal to 14 serotype, as well as to tetanus. We looked at proliferation, and he had about 50% of control to pokeweed and about 80% of control to PHA. We did a flow cytometry panel looking at CD11 and CD18, and that was considered normal expression. And then he had a TLR assay done, and he had decreased cytokine production for TNF-alpha, IL-1 beta, and IL-6 in response to stimulation for TLRs 1 through 8.
So
he did have normal growth.
So Roni has been trying to convince us that this is Nemo for about minutes now. Why don't you go ahead and help us figure out what this is? So there are still some folks thinking this could be LAD. Kieran, what are the parts that are, in your mind, consistent with LAD or inconsistent with LAD?
The elevated white count could be consistent with LAD, at least for LAD type 1. He has normal expression of CD18, so there still could be some type of functional defect with normal expression. That could still go for that. For LAD type 2, they typically present with short stature and mental retardation. And then LAD type 3 is similar to LAD type 1, but with a bleeding defect, and there's no history of that. So still could be possibly type 1 with normal expression, but maybe a functional component.
So if we could just pause here for a moment. So faculty that are on the call, so have a few central findings here. I guess I'm not, I didn't numbers or anything. I guess I'm not that excited by the proliferation studies, but the no antibody responses to pretty much anything the child's been vaccinated to is slightly worrisome. So are there things that we should be thinking about that haven't shown up on the differential list yet? Faculty, are there anything that you would want to add, not necessarily that it's the answer here, but that we should think about in this context? Faculty, I think that you're actually unmuted, so you can talk if you want.
So the regular old hyper-IgM has the kind of similar profile, even though there's other things that don't go along with it.
And what would you think would be inconsistent with hyper-IgM?
The teeth and the ectodermal dysplasia part. Except for the hyper-IgM phenotype of Nemo, right?
Yep.
I don't know if SSD was
I'm not sure who's speaking, but we're having trouble hearing you.
Okay, this is Morna. I'm late to this call. I apologize. This is. I don't know if XLP was a consideration differential here, but it might be. Certainly, the poor response to vaccines could be consistent with that.
That's a great thought. I'm just going to repeat it because you're coming in very, very faint. So Morna joined us and thought that XLP should be on the differential. having absent responses to vaccines absolutely can be seen in XLP1 and 2. This IgG is maybe a little high for a 6-month-old, but absolutely I think should be on the differential. Very, very nice idea. And we have some comments coming in looking for other causes of high IgM and low IgA. And I wonder if Sergio is on the phone and can give us a quick rundown of that. Well, I thought he was on. So I think that, you would, certainly there are some cases of common variable that have a low IgA and a high IgM. Oh, Sergio says he's here, but yet you are not speaking. Oh, he's muted. Let me see if I can figure out how to unmute him.
Push *6 on the phone.
Oh, I do know how to unmute you. Hang on. Uh-oh. Can't unmute you, Sergio, because we're maxed out on unmuted people. Hold on, I'm just going to briefly mute Elena. So sorry, Elena. Oh, Sergio, sorry. You're going to have to type because I can't unmute you for whatever reason. Would you like to type a little differential for us so that you can play in our sandbox too? So meanwhile, I will say a low IgA is always something to be concerned about in the setting where you're thinking about an immune deficiency. Clearly there's isolated IgA deficiency, but that's not really the setting that we're talking about. So in a setting with recurrent infections and some other abnormal labs that I know Kieran's going to talk about, you would, common variable just statistically is going to be the most common. I think that, I've never seen an XLP case with a high IgM. Someone just pointed out ataxia telangiectasia, absolutely. There are other class switch defects other than X-linked hyper IgM, so and AI. So certainly there's a fairly broad differential, and now Sergio did not give us the differential, but he's pointing out that you can use a CD3 stimulation and flow cytometry. Does everyone know about the IKB alpha degradation flow cytometry? That's a really nice diagnostic maneuver. So you remember that in the NF-kappa B pathway, that IKB alpha is what sort of gets ubiquitinated and gets degraded. And you can look at that degradation using a flow cytometric methodology. We don't offer it here, so I don't have any personal experience with it, but when I see it in talks, it looks really, really... So, Kieran, maybe you should keep going.
So this is our differential for the lymphocytosis. So sort of non-immunodeficiency causes would be infection and malignancies, and he had a bone marrow as well as flow cytometry on the bone marrow to rule out any form of lymphoma, and he had no monoclonal species identified. And then, going through the list of the differential, we thought about leukocyte adhesion defects, ALPS, and then CARD11 mutations. But on our highest order differential was ectodermal dysplasia with immunodeficiency, either autosomal dominant or X-linked. And this patient turned out to have the autosomal dominant form as the etiology of his lymphocytosis and absent vaccine response.
I think the most striking thing about the labs that were presented were the paucity, extreme paucity of any RO type cell compartment. This child is 2 years old and could have more than just 1% or less memory cells. So that, I think, brings to mind conditions like Karen mentioned, the NF-kappa-IA and also the CARD11 mutation, which a lot of that kind of large population of cells, the large population of RA, 5 RA positive cells.
It's a very consistent feature of that category of disorders, right? In the NF-kappa B pathway, you just don't get good memory formation, either in the T cell compartment or the B cell compartment, because they both depend upon NF-kappa B for that memory conversion. So it's a very consistent phenotype, as you mentioned, for NF-kappa B pathway proper, but also CARD11, and if I'm not mistaken, MALT1 as well, I believe, that same phenotype. Someone else knows the answer to that, but I believe MALT1 also has that phenotype. Do you want to talk to us a little bit about the NF-kappa B pathway and the lymphocytosis? That's, I think it's a very underappreciated association, and actually I was not aware until I saw your case. So do you want to tell us a little bit about that association and what you imagine is going on?
Sure. So I actually reviewed the literature on all the I-kappa B alpha patients, and that's the next slide that I displayed here, and they all had this sort of striking lymphocytosis going on. And NF-kappa B is important in proliferation after activation with either the TLR pathway or other signaling pathways. So I think this is all due to that pathway, but I don't know the exact. I can't give you an exact mechanistic explanation very well right now.
It's also, again, this was not an association I was very familiar with, but I did look up some NEMO cases as well, and about a quarter to a third of them had quite high white counts as well. So it must be, again, part and parcel of that pathway. You could imagine, I suppose, that the NF-kappa B pathway is related to adhesion and migration of these cells, not so differently than the LAD, but just a signaling component rather than the adhesion molecule component. So I don't know that that's the case, but you could imagine that it plays some role, I suppose. Karen, do you want to tell us how your patient did and what your plans for management are?
Mm-hmm. So he's currently doing well on IVIG as well as prophylaxis. So we have him on prophylaxis for Group A strep as well as for viral HSV. I'm sorry? As well as for HSV. And we're actually planning to transplant him.
Your line is now unmuted.
So we're currently in the midst of trying to find an unrelated donor. But unfortunately, the outcomes currently in the literature aren't the best. There's only one patient who's currently well and live. First reported by Dr. Casanova's group. And there is some concern that in mouse models that these mutations lead to poor secondary lymphoid organ development, and that transplant may not be a curative option.
Someone has cells and they need cells.
Getting a lot of feedback.
Hang on just one case. I'm going to try and.
All attendees are muted.
Can you hear me? Okay, I'm going to
Yes.
presume you can. Sorry, I had to mute a bunch of people for the feedback, but I believe the presenters maybe aren't able to talk still. So, Kieran, do you want to just repeat, first of all, because of the feedback, could you just repeat what the gene defect is and talk a little bit about management?
Sure. So the gene defect was in the I-kappa B alpha gene, and so it results in inability of the gene or the protein part to be degraded, and so results in sort of tonic inhibition of the NF-kappa B pathway. Currently, this patient is being managed with IVIG due to his poor vaccine response in the past, as well as antimicrobial prophylaxis currently. So we're treating him with amoxicillin to treat for sort of group A strep and other pyogenic species. We're also have him on antiviral therapy with acyclovir for prophylaxis for HSV, as well as Bactrim daily for staph prophylaxis. And our current plan is to transplant him. Unfortunately, the few cases that have been reported, the results are a little bit on the dismal side. So there's only one patient currently alive and well in the literature, and that was Dr. Casanova's group who first reported this patient, or this defect, who's doing well. The other ones, a total of 3, 2 died from sepsis, 1 5 years after his transplant, and another one died from autoimmune chronic GVHD etiologies at day plus 200. There is one mouse model looking at this that proposes that secondary lymphoid organs do not develop well, and so that may be an etiology for some of these sort of late sepsis type pictures seen in these patients. And so there is a possibility that maybe transplant may not be a curative option given the lack of secondary lymphoid organs that may not be present in some of these patients. But our plan is to try to do a transplant because we've talked to Dr. Casanova's group, and it sounds like, this patient's doing well, now almost 8 years out from their transplant. They're a teenager now, so that's our current plan.
And Karen, I noticed you didn't mention Zithromax for mycobacterial prophylaxis. Is mycobacteria less of a risk in this disorder than Nemo, or you just didn't get there yet?
Sorry, I actually forgot to mention that. So he is on azithromycin prophylaxis as well. There's, I think, only a couple of patients that have had it, but again, I think the case series are so small.
So
mycobacterial disease.
Interesting. And do you have a sense of overall whether the risk of mycobacteria is lower in I kappa B alpha than I kappa gamma? Sorry, hard to say. Do you have I'll just say Nemo. Do you have a notion of whether it's the risk of mycobacteria is lower in I kappa B alpha than in Nemo?
I think the numbers are so small. I think it's hard to make that distinction. I know Casanova's group puts them at risk, similar to the Nemo group for tuberculosis in one of their reviews for common infections in the NF-kappa B pathway group.
And Sergio just made the point that they have seen disseminated BCG with I kappa B alpha. I wonder if any of our South American, Central American, or Mexican colleagues where BCG is used have seen a patient like this with BCGosis. I would imagine that it is a fairly common presenting manifestation for either Nemo or I kappa B alpha. Is that true? I'll wait for some folks to chime in on the chat side. Karen, is there anything else you want to tell us about this patient? Really fascinating. So great to highlight an unusual diagnosis.
No, I think, I know Sergio had asked about the anti-CD3 panel. We're sending that on him, so we want to see if he's similar to the other patients because they tend to have this decrease in stimulation to CD3, CD28, that's rescued with CD28.
Correct me if I'm wrong, the mechanism of that is that CD28 signals through a PI3 kinase pathway that's not as dependent on NF-kappa B, is that right?
I think so, correct.
Do you have some answers from South America? So Beatriz has told us that she has a similar patient who presented with BCG. Armando also has. So I think it's to remember that BCG is a really important sentinel category of immune deficiencies.